I'm the Vice Chair of Education in our department and the coordinator of the Grand Round series. I'll turn it over to our chair, Dr. Neglia, to make a few announcements, and then we'll get started with our speaker.
Great, thank you, and good morning, everybody. Thank you for being here for Grand Rounds. We have a great group of people discussing autism this morning. I think there will be a lot to learn. I just had a couple brief announcements for you. First is to please watch your email today and tomorrow. This is our week for WineFest. WineFest, as you know, is our big annual fundraiser that supports research in the Department of Pediatrics and in children's health in general. This year, WineFest is virtual. You can go to WineFest in your home. The upside of going in your home is you don't have to get dressed up, and you don't have to pay $200 or $150 for a ticket to have dinner. So there are some upsides to WineFest at home. But I'd encourage you to watch your emails, sign in, consider a donation, consider just being a part of the event. So that's coming up this week, and I will be sending a notice out later on today with some more information. The other thing that we all saw yesterday that we've been hearing about for the last 10 days, 14 days or so is the university's plans for a salary reduction. So I was not at the University Senate meeting, and I have not seen the actual document that details the complete plan. There's a table out there that shows a graduated reduction based on the university salary, but I believe there is also a component of this that requires the medical school to look at common paymaster faculty who already had a salary reduction and how this fits together. So this is, now we've got permission to start working on it. It's only been less than 24 hours. So please give us a little bit of time to try and get some clarity around this, and then we will arrange for a town hall for the faculty to get this moving. Finally, in terms of other things that are moving, clinical research sunrise is coming. Again, if you have clinical trials, clinical research going on, please pay attention to your email and look for the pathways to actually get our clinical research back moving again. Nothing has come out yet. The plan is due to the dean this week. I imagine we'll see something first thing next week. So with that, thank you. I'll turn this back to Dr. Borman-Shope and we can get started.
All right, well, it's our pleasure today to welcome a speaker from our Clinical Behavioral Neuroscience division, and I'll let that division director, Dr. Chris Boyce, do introductions of our speakers. I'll take it away.
Sure, thanks, Emily. So I'm really pleased to introduce Dr. Amy Esler, who is the division director, or excuse me, the section head of the Autism and Neurodevelopmental Disorders program here within our division. I think autism is particularly affected by COVID-19 in a way a little bit different than other populations in terms of it's so dependent on facial expressions, and the interventions are wrapped around learning facial expressions, where when people are masked, it makes it very difficult for those kids to both have their intervention, for us to do assessment of those children, and then to address the anxieties that might come from both the pandemic as well as the events surrounding the killing of George Floyd. So this is going to be a really interesting panel to help us understand what's been going on in the world of autism under the current events, and I'll turn over to Dr. Esler and her panel. So thank you, guys.
Thanks, Chris. Good morning, everyone. I have no financial relationships to disclose, and I'm not talking about any meds or devices today. So if somebody had told me a year ago that I would be giving a presentation that covers prevalence, police brutality, and a global pandemic, I would have thought they were crazy, but here we are. All of these things kind of impact autism today, and so hence the title of Autism 2020. So I'll spend some time talking about how each of these issues are impacting the families we see, the focus on what we can do as medical providers and clinicians to support families, And then at the end, I have a nice panel of experts in not just autism, autism plus neurodevelopmental disabilities, to just talk about what we've been seeing and take any questions you have about ways you can support families and do modifications so that visits go more smoothly. I'm going to start off because just before everything shut down, our new round of prevalence statistics came out. So I'm going to update you on the numbers of children with autism in Minnesota and across the nation. And this data is important because it can show you how to use health and education data to understand different trends in diagnosis and the broad developmental and behavioral characteristics of autism, and it helps us identify areas where we're still falling short in terms of health disparities in identification of autism. Minnesota has been looking at autism prevalence for a long time now, and our involvement in this work really started out as a grassroots effort in the Somali community. In the mid-2000s, there were concerns among the Somali community that they were seeing higher numbers of children with autism than expected based on their overall population. And so there was some real parent advocacy at the state and federal level to say, come and look at this. Are we at some sort of unique risk for autism compared to other children? So the first thing that happened was the Department of Health did a study of Minneapolis autism preschools. That was one of the places where Somali families were seeing high numbers of Somali children. And that study looked at 3 different years of enrollment in ASD-specific preschool programs in Minneapolis. And they did find higher than expected numbers of Somali children attending those programs, but the numbers really varied from year to year. And in some years, there wasn't a difference in prevalence. So it kind of ended up raising more questions than answering. So in 2011, we were funded, the university was funded to take a closer look at this issue. Our first step was to look at prevalence rates within the city of Minneapolis. So we compared white, Somali, non-Somali, Black, and Hispanic children's prevalence rates, and we did not find a significant difference in the rate of autism among Somali children compared to white children. Their rates were essentially the same. However, we did find that 100% of the Somali children with autism also had co-occurring intellectual disability. And this matched up with community concerns that not only were there more Somali children with autism, but they seemed to have a more severe form of autism. In 2015, we were funded to join the CDC National Autism and Developmental Disabilities Monitoring Network, and we were refunded again last year, so we've now completed 2 rounds of data collection and analysis. One of the reasons this is so important is there's a link with autism fears and vaccination rates in the Somali community. So while these questions about prevalence were being asked, vaccination rates began to be affected. And Somali children really started out with high vaccination rates, which then plummeted in the mid-2000s. You can see it went up a little bit again in 2017. So this is 2-year-olds. So this 2015 actually corresponds with 2017. And that's when we had our measles outbreak, you probably remember. But once that subsided, things started to go down again. The other thing that happened was in 2008, anti-vaccination groups really started targeting the Somali community, and there were multiple visits by Andrew Wakefield to the Minneapolis area. So the question of whether there's increased prevalence of autism among Somali children had a significant influence on public health. So Minnesota is part of the ADAM, the Autism and Developmental Disabilities Monitoring Network. There's 11 different sites throughout the United States. And this map is showing you, the green is the areas where we do surveillance. For Minnesota, that's Hennepin and Ramsey counties. And we look at children who are 8 years old in the surveillance year 2016. And in Minnesota, we have a specific interest in looking at Hmong and Somali children in addition to the other racial categories of Black and Hispanic. So we look at a specific geographic area and a specific calendar year. And this is how we define prevalence. We count the cases of autism and divide that by the total population. And this was our total population in 2016, the calendar year 2016. So we had almost 14,000 8-year-olds in our denominator, relatively diverse population to look at. And here were our findings. So I'm going to alternate between showing you the national findings and then our state findings in Minnesota. The autism rate is now 1 in 54 nationally, or 1.9% of the population. That's up from 1 in 59 in 2014. You can see prevalence has been going up pretty steadily since we first started tracking these data. We think most of that is due to the broadening of diagnostic criteria to include milder cases, but there is a percentage of that increase that we just aren't sure what's happening. It could be premature babies living longer, it could be older men having children, but it is a real increase. In Minnesota, our prevalence, we only have 2 data points to look at, but our prevalence stayed essentially the same. In 2014, it was 1 in 42. In 2016, it was 1 in 44. Not really a significant change, but about 2.3% of our geographic area. Looking where we rank with the other ATOM sites, in 2014, Minnesota had the 2nd highest rate of autism, and now we are 3rd to North Carolina and New Jersey. But our prevalence is significantly higher than the national average. One of the things we look at is autism rates and whether they vary by race and ethnicity. We know that they vary by sex. That's been a pretty consistent finding, that boys are more likely to have autism than girls by a rate of about 4 to 1. That was held up again in our 2016 data. And traditionally, we have had significant differences in prevalence across race and ethnicity, which we know is due to lack of access to evaluations that result in an autism diagnosis. This year was the first year we did not see a significant difference in prevalence for Black and white children. So they had the same prevalence rate, basically. Although we are still seeing lower prevalence rates for Hispanic children. And Asian also did not have a significant difference. In Minnesota, we look at those same race and ethnicity categories, but we also separate out Somali and Hmong, our populations of interest. In terms of sex differences, we found the same type of ratio. So in our state, boys were 3.9 times more likely to be identified with ASD than girls, and that's consistent with national estimates. It's for boys, the rate is 1 in 27, and girls, the rate is 1 in 118. We also, once again, did not find any statistically significant differences in prevalence by race and ethnic group. So the prevalence estimate for Somali children was 1 in 34, and that, again, our overall rate was 1 in 44. And the rate for Hmong children was 1 in 62. So although those numbers sound and look different from 1 in 44, our sample sizes were really small. So we weren't really able to tell if those differences were real or occurred by random chance. So using a p-value of less than 0.01, these differences were not statistically significant. The confidence intervals also are quite large, so we should use caution in talking about and interpreting these numbers. So the best thing to say for now is we did not find differences in prevalence across race and ethnicity. One consistent finding we still found again this year is that we are seeing differences in co-occurring intellectual disability by race. Overall, rates of intellectual disability within autism have been going down over time. We used to think the majority of children with autism had intellectual disability. We used to think half of them would never learn to speak. Now that's vastly different. We're identifying milder cases, and only about 1/3 of children identified had IQ scores under 70. However, this did vary by race, and Hispanic and Black children identified with autism were more likely to have intellectual disability than white children. In Minnesota, we found a similar trend. We had 25% of our population had co-occurring intellectual disability overall, but for Black non-Somali children, it was 36% and 45% for Hispanic. Note that Somali children had a rate of 37%, and again, because of small numbers, it's not significantly different from the overall rate, but it's far different from the 100% co-occurrence of intellectual disability that we found in our Minneapolis study. So both in 2014 and 2016, we found that less than half of the Somali children had intellectual disability with their autism. So we're not replicating that finding. We're not continuing to see a more severe form, at least in terms of intellectual disability, in our Somali population. Another critical variable that we look at is age of identification. We know that you can reliably identify autism by 24 months, often sooner than that. Behavioral features start showing up reliably at 12 months of age, but our median age of diagnosis has consistently been after age 4. So this is our national data. The median age of diagnosis was 51 months. And another kind of depressing statistic is not only are we not identifying them, but we're not referring kids for any kind of evaluation prior to age 3. So only 43.6% of our children with autism had received any kind of comprehensive evaluation by age 3. So that would include a speech language evaluation or a help me grow birth to 3 type of evaluation. They weren't getting those either. In Minnesota, the data is even worse. Our median age of diagnosis is after age 4.5. And only 39% had any kind of evaluation prior to age 3. We also look in our data to document when concerns were first reported. So when did parents or a physician or anybody say there were concerns about development, either late talking, late walking, anything. And the vast majority had some sort of concern verbalized and documented prior to age 3. So if the majority have concerns before age 3, but for some reason we're not even referring them for evaluation until after that, and then we're not even diagnosing them until over a year and a half later, how much early intervention are we missing out on? A lot. So this is one of our important statistics to come out of our data. And this has not moved. As early identification, autism awareness efforts have increased, we aren't moving the needle back at all. So some of the limitations of our data is, we're looking at Hennepin and Ramsey counties. We can't generate that necessarily to the entire state of Minnesota. We can't generalize all of the ATOM sites to the whole country. So that's a limitation. In Minnesota, we continue to be plagued by small sample sizes, particularly for Hmong and Somali children. So we're still kind of limited in our ability to detect real differences there. We need to continue to search for funds to expand our geographic area to statewide, which we are hoping to be able to do that in the coming years. And we're also just looking at 8-year-olds, not all age groups. So age 8 was selected because the rationale is that most children will have come in contact with some sort of formal, education or medical setting by that age to have their diagnosis detected. But we want to keep the age young enough so that the data we're looking at are relevant to our current practices. But we don't know if these same statistics apply to 3-year-olds today or 20-year-olds. Why is this important? Well, this data tells us who has autism and how we're doing with identifying autism equitably across race and ethnicity. It also tells us the support needs that we might have in our communities. 2% of the population has autism, and they're going to be adults soon, and we need to make sure we have supports in place for them. We also learned from this data that we continue to struggle to refer children early for the kinds of evaluations that will promote specific interventions to help with their development. So we really need to focus our efforts on that area. If you want more information or data, here's our website. We have a nice printable handout you can use too. And I just want to acknowledge my colleagues, my co-PIs, Amy Hewitt and Jennifer Hall-Landy. in ICI, and our project coordinator, Libby Hollis-Moko. So that's sort of the broad picture of where we're at in 2020 with autism. And then of course we have these two really important and salient issues happening right now. The first thing that happened, of course, is COVID-19. And there's already evidence that it's disproportionately affecting individuals with autism and neurodevelopmental disabilities. There are specific risk factors for COVID-19 in people with autism. One is that co-occurring conditions are quite common. The minority of people with autism only have autism. There's seizures, and the stats on this are pretty wide-ranging. Anywhere from 4 to 38% have been found, but a large survey, parent report survey, documented about 8.6% had seizures with autism. They also have high rates of obesity, higher than the general population. So again, estimates vary, but between 35 and 67% of people with autism have obesity, children and adults. It's also possible that autoimmune conditions are more common in ASD. Parents certainly report higher frequency of GI conditions and other autoimmune conditions. And then there's characteristics of autism that can increase risk. So they may have sensory issues where they just can't tolerate wearing masks, so they're less protected that way. If they're younger or more impaired, they might not understand social distancing. They might have some impulsivity that makes staying away very difficult. When we're working with young toddlers on and off the spectrum, it's really hard for them to stay away from an adult sitting on the floor with them. So they're coming into contact more often with people. They also have receptive and expressive language deficits. So following instructions and being able to verbalize their symptoms can really impact their vulnerability. And children who are minimally verbal tend to have more doctor and ER visits than kids who aren't. And that's just often because they seem off in some way and the parents aren't sure if something medical is happening. So they're interacting with medical people more. There are also high occurrence of mental health conditions in autism. Close to 50%, or even some statistics say more than 50%, have anxiety and depression. And irritability and just general dysregulation is common. As I was preparing this talk yesterday on NPR, it was morning edition, this study was talked about. And so now we have data to show that people with intellectual disabilities and autism are impacted by COVID more significantly. So these are adults with autism and intellectual disabilities who are living in congregate care. And their case fatality death rates are higher than the state overall in New York and Pennsylvania. So these things have been real concerns for families of children on the autism spectrum. Also, just, we're all worried about the same things. And in kids with autism, it's often just enhanced or magnified. So it's hard to cope with unknowns. It's hard to have your routine interrupted and to not know when things are going to go back to normal. I was talking about earlier this morning, we tell people with autism, we tell parents to do a visual schedule so that everything is predictable, to have a first then, like first you do your math, then you get iPad time. Well, you can't really do that with COVID because we don't know when it's going to end. So that's really difficult. You can't make this predictable. There's also the normal loss of connections with friends, teachers, and therapists. So not only are kids with autism seeing their teachers, not seeing their teachers anymore, but they may have therapists outside of school, or if they're young, they may have therapists every day that they're not seeing in the same way. And they have the same fears about catching the virus. It's just maybe a little bit harder for them to understand or respond, or they have different responses to that fear. When COVID-19 was a little bit newer, so I think this was in April, I'm part of a Minnesota Senate Autism Council that sends policy advice to the legislature. And we had a town hall meeting where we invited families and children to come, well, families mostly, to talk about what they're concerned about with COVID-19 and what recommendations they have. And their fears, they have a lot of fears about health equity. So they're worried about what if their child gets COVID and their visitation is limited, and parents can't be there with them. Parents of adults can't be there with them, and they feel their child needs an advocate in what's going to happen. They also many of them have had really negative experiences with healthcare providers who aren't familiar with autism. Inappropriate practices, sometimes really frightening experiences can lead to trauma. Times when children have had to be held down by multiple people for a blood draw or tooth cleaning. And that just, the thought of going into the emergency room for a COVID check and possibly being admitted is really terrifying. But also parents worry, what if I get sick? It's a lot harder to find a backup caregiver for a person with autism, especially if they have challenging behaviors, than just a run-of-the-mill child. And there's equity concerns. Parents voiced a lot that they're worried if their child needed a ventilator and they were, there was a low supply, that their child would be last on the list. There's concerns about diversity and equity. A lot of families talked about, not everybody has access to Wi-Fi, and everything we're doing right now, everything is telehealth, and it relies on reliable Wi-Fi, and it relies on English literacy, and that is leaving a lot of families out. So the recommendations they had were to have organizations reach out to families and help them develop like a one-page plan that will be respected if medical treatment is required or if they're brought to the emergency room. They also want to be included in any decision-making and policy planning, especially the ethical decisions about distribution of resources. They also expressed that sometimes, maybe they're not being treated unfairly, but things aren't explained in a way that reassures them of that. And I've had a lot of parents tell me that they feel like the doctors are just chalking everything up to autism when there may be a real underlying medical condition present. I recently had a mom whose son had some unusual sleeping patterns, and she went to a sleep specialist with concerns about narcolepsy. And the first sleep specialist said, nope, it's not narcolepsy, didn't explain it, didn't take a lot of time with her, so she didn't really feel good about that. And she went to a different sleep specialist, and that sleep specialist agreed this is not narcolepsy, but explained that it was because the pattern the mom described didn't fit that. So it was the same outcome, but the second one she felt better about because she knew why they were making that decision, and that it wasn't just, we're not going to look into this because it's probably just autism. So what can we do as providers? There are a lot of, it's almost like overload out there. There are so many resources for families, providers to help prepare people for COVID-related doctor visits or just coping with COVID in general. So I selected a few just to show you a few of the tools that might be helpful. It's really helpful to create these things called social narratives. They're visual with a little bit of text, stories about what's going to happen during your visit. And this one that I'm showing is a great one that was made by Boston Children's Hospital. This one is the one about getting a nasal swab and potentially having to go to the hospital for COVID. And it includes everything from like walking, why you're there, what you're going to see when you get in there, and what's going to happen to you. Those are really helpful in making the visit predictable, and parents can rehearse it ahead of time. When you're at your visit, I think one of the things we're probably all learning about COVID and telehealth is that everything is taking a lot longer. And in person, that's going to be the same thing. I'm on a national call every other week with, I think, like 150 clinicians around the country working with autism. And some of the clinics have opened up to in-person visits again. And they talk about, things are just taking forever. Handling waiting rooms and getting into the room by themselves and social distancing and PPE and cleaning equipment, all of that is adding time. And children seem to need more of a warm-up when you're walking in with a bunch of PPE on. So they're taking extra time there to make kids comfortable. And the other thing that we're seeing, and hopefully I'm not showing today, but I feel it every day, is just the additional background stress of COVID-19 just makes it harder to concentrate, to be eloquent, you're losing your train of thought all the time, and that's adding time. So just make sure that you are allowing that space so that you're not taking, everybody's baseline is going to be higher stress, and to feel rushed will just make things worse. You can also, especially if you're a pediatrician in like a medical home, it'd be helpful to make these kind of one-page summaries available to families and let them know that these exist. They're just one-page profiles that describe their child, could be an adult child, and talks about what their needs are, and have these prepared in the case, the worst case scenario. Have a go bag and put the sheet in there, have multiple copies, laminate them so you can wipe them down. If you happen to need to be in the hospital, post it around the room and move it with them so that all new providers can see this one-page profile sheet. And the goal is something you can read in less than a minute, and something that tells you about the person as well as the presence of a disability, what is important to the person in the context of their hospital visit or their clinic visit, and then how can the provider best support and help the person feel less anxious. So these links, you can find examples here, and I threw some up here as just nice examples. They're not rocket science, right? Like, this is pretty easy, but this is some nice COVID specific information that you might want to gather right now. There will be a PDF of this presentation available on the Grand Rounds website, and you should be able to follow these links to find these tools. This is another one I like a lot too. This one, the link on the previous page takes you to this page. The other thing you might need to know about is that masks might not be tolerated by some kids with autism. So this was an article that appeared in the Washington Post, written by a mom of a teenager who was really trying to tolerate the mask, but just not getting there. And there are many reasons that kids might not be able to tolerate masks. The feeling of restricted airflow can maybe send them into a feeling of suffocation and increase their anxiety to a level where they're unable to participate in the visit. There's sensory sensitivities where some kids just really don't like the feeling on their face. They just can't stand it. There's visibility issues, as I'm sure everybody knows about. And then there are safety concerns if there are distinctive pre-seizure facial expressions that get hidden under the mask. You can mitigate some of this by helping parents prepare for visits, know that a mask is gonna be, I don't know if you wanna say required, but highly recommended. And also just know that not all kids are gonna have difficulty with this. But if you are a provider who sees a lot of children with autism, for chronic conditions where they're really increasing their risk by not having a mask, there are things you can do to build tolerance. So here's some other links to some of those resources. We're going to have on our Voyager page a specific social narrative on coming to the Voyager clinic, and some websites with tools for parents to help prepare for medical visits. And in the case of having a child who's going to frequently need to come to clinic and needs to wear a mask, we'll also have some tips for parents on using behavioral strategies to increase their tolerance. So that's COVID, which is kind of a big enough issue. But now we also have George Floyd's murder and the police brutality, and this is bringing up a lot of concerns and feelings in the autism community as well. Some of you may remember there was a young adult with autism, or no, sorry, he was a teenager, 14-year-old boy with autism in Arizona. And he was hanging out in a park across the street from where his mother had some sort of appointment. He was just hanging out. He had a string that he was dangling, and he was kind of pacing and dangling it, something that helped him kind of self-calm. And a police officer noticed this and approached him, thinking that he was on drugs. And because the teen had autism, he didn't really know how to respond to this and just said, "No, thank you," or something like that, and walked away. And boom, the police officer tackles him and beat him pretty badly. You can see the injuries he sustained here. So that was a terrifying incident, and all the person was doing was stimming, to self-calm. So this headline kind of says it all. We know from research or just understanding autism that there's increased vulnerability to negative outcomes with the police for those reasons, that they just, maybe don't understand the situation. They don't know how to talk to the police in a way that helps them understand that they're not on drugs or they're not involved in a crime. And there was a study that had an experimental condition that kind of showed that kids with autism were worse at explaining to police why they weren't involved in a crime in this little vignette they presented than typical controls. There have been some responses to this issue, and St. Paul is one of the police departments that uses this new app called the Vitals app. And if you sign up for Vitals, your child gets like a little GPS thing that they wear. And if the police comes within a certain distance of your child, the police get a ping on their cell phone that tells them, oh, you know, here's, this is Devante. Here's Devante, he has autism, you know, just to give them a heads up on what might be happening. And then if the police end up having to interact with the child with autism, there's other tools like parents can record a video saying, you know, hi, Devante, it's your mom. It's okay. You can go with him. You know, they're going to call me and I'm going to come get you, or whatever reassuring thing. So that's great. And a lot of people feel good about that, but there are also particularly families of diverse children who maybe aren't so comfortable, like having the police know where their kid is, you know, and that the child has autism. Some of the statistics on this, so there's a large survey in Pennsylvania of over 2,500 caregivers, and they found that 7.9% of elementary and high school students had some kind of police contact. Most of those were children aged 13 to 17. And also having any kind of serious psychiatric condition that required an inpatient stay, that increased the risk of police involvement ninefold. And so now you've got the dual concern of police, you know, already maybe not knowing the best ways of handling a person with mental illness, plus autism on top of that, increases concerns. There's health disparity issues as well, where parents who are lower income, their children having more contact with police than higher income families. So that's the backdrop. And we reached out to our families to find out how they're coping right now with the killing of George Floyd and how they're talking to their children about it. And the first thing, you know, we're going over this just to send the message to those of you who aren't that familiar with autism. I think there's a stereotype that people with autism, you know, are kind of oblivious. They're immune to some of these social difficulties, but it's really not true. They have passionate reactions and beliefs. Some people, you know, really focus on politics and current events and are very affected by things like this. And it's also tricky to talk about race with children with ASD who tend to be more literal and concrete and lacking appropriate social filters. So this was a mom whose child had a Black babysitter, and he would always comment on the color of her skin every time she came over. And his mom was saying, like, well, I have this neutral way of dealing with it, but at the same time, it doesn't really honor the fact that skin color in this country has serious implications and leads to unfair treatment. But do you want to bring that up every time the babysitter's coming over when you're trying to go on your date night? So it's just hard to navigate. We also got some reactions from our patients. Dr. Hudak will be here in a minute, but we have treatment groups for children on the spectrum, teens on the spectrum. And we reached out to some of them to find out what they were thinking and got these responses. This teenager with autism here, you know, really went through quite a journey in thinking about this and has, I think, a more sophisticated take than a lot of adults and posts that we might see on Facebook. But he talks about, you know, it's hard to believe me that I'm affected by this because I'm white and autistic with ADHD, but high functioning. And then he also talks about at first not really liking when people start looting and burning things down, but over time I start to think that the riots were worth rioting about. I keep asking myself, what's so good about rioting? Now I know that riots happen because people want to send a message to make change. So his mother shared too that they went to the intersection of Chicago and 38th Street to look at the mural. And this boy who made this really, you know, insightful statement was so overwhelmed by emotion and couldn't cope with them that they had to leave after about 3 minutes. So you have that dichotomy where, you know, some of the things that they're thinking and saying are so insightful and so mature, but they still have these difficulties in the moment with coping and dysregulation. And this was a 10-year-old boy, one of our patients, and he wanted to share his thoughts kind of social media style. So his mom wrote the question and he wrote out his answer here and took a picture. for me to share in this presentation. These are things that Simon thinks about a lot. He just discovered racial inequality in the past couple of years and has been quite bothered by it. There's also equity concerns here. There are a lot of people with intellectual developmental disabilities who are diverse and feel that there are, you know, kind of a double whammy happening, where first they're discriminated against by their race, and then they're misunderstood and discriminated against because of their disability. This man his name is Noah McCourt, and he is a St. Paul resident and autistic self-advocate who is, you know, he's all over the place. He's really on the front lines of disability advocacy issues. So he's been a real asset to our state. And I think he was BuzzFeed Person of the Week one week. So what we can do to support individuals with ASD and through uncertain times are these kind of 7 things. So support and understanding, this is about using visual supports, social narratives, the things I talked about before, to help parents, you know, talk with patients in concrete language, direct language, so that they can understand, you know, what COVID is, what police brutality is. And then give them opportunities for expression. You can tell parents to give their children multiple opportunities to talk about these issues in multiple ways. Maybe there are different ways that they can express that isn't verbal. Schedule regular times throughout the day for calming and coping activities. Make sure the child has access to those calming and coping activities and to physical activity throughout the day, throughout the week. And in hospital settings, clinic settings, can we be flexible in the midst of COVID and letting kids bringing in some of their fidget items or soothers, even if there might be a germ issue, just so that they can regulate and participate in the appointment. And so you don't have to, you know, move up to more restrictive procedures that definitely bring physical contact. Parents can help their children by maintaining some regular routines, meal times, sleep and wake times, visual schedules, but also build new routines. So making sure that the child has opportunities to make choices throughout their day, create spaces in the home. Now we have this school space and now mom has this workspace. Foster connections from a distance, but also be aware of changing behaviors. So some signs of anxiety and depression in people with autism are going to be more like changes in eating and sleeping patterns, changes in daily living skills, changes in repetitive behavior, increases in irritability. They may not be able to self-report as much on their internal mood states, but these changes in behaviors might indicate there's something happening. Just a couple quick slides left before our panel comes on. These were some pieces of art that a couple of teens, or one of our teens from a social group did to express herself in terms of George Floyd. And again, more resources are available on coping and calming and all kinds of things. If you have not discovered Kosmic Kids yoga yet, I highly recommend it. This is actually my child doing it, but she is amazing. She does yoga, but tells a really interesting story, and it's absolutely captivating. More resources for you to peruse after this. But now I want to turn it over to our panel. Hopefully they can unmute themselves and unmute their cameras and join. We have 3 more people who are experts in autism and other neurodevelopmental disabilities. Dr. Andy Barnes, who's our developmental behavioral pediatrician in Voyager, one of our developmental behavioral pediatricians and associate professor. Dr. Rebecca Hudock, who leads our training groups, our treatment group component in our clinic, and Dr. Julie Isengart, who is a pediatric neuropsychologist and director of the Neurodevelopmental program in rare disease. So I have questions I can ask the panel, but also we can just take questions. Let's start by taking questions from the audience too. I see Becky up there. I see Andy and Julie.
I don't see any questions coming in yet, but I think certainly the ones you have on the screen are a great place to start. And if our attendees, you can feel free to put questions in the chat or in the question and answer.
Yeah, so I know some of you have started to do some in-person visits. So how have they been going so far, and what kinds of wrinkles have come up or issues that parents have brought up?
Amy, are you asking if, among the panelists who's been, okay. So we've done some neuropsychological evaluations for some of the children with rare diseases, and the parents are sort of going back and forth between really being concerned about being able to track how their child is faring, because what's on their mind a lot is what's the neurodevelopmental trajectory, knowing that my child has a condition that has some potential for neurocognitive decline. So they're sort of weighing that with not being exposed to the risks that are associated with COVID in particular. And so far we've had conversations to prepare, and particularly we've talked about comfort levels with masking. A lot of these children have actually had a lot of experience with masking as part of their treatment, particularly if they're bone marrow transplant patients. So that part has worked okay, but there is definitely overlap with a lot of the dysregulation that you're describing that we know to be associated with autism by nature of the fact that these children do have brain disease that can impact their regulation. So we make calming preparations. We have conversations with parents ahead of time. And fortunately, many of these patients we know, and we know the tricks to soothe the children.
There's a question for Dr. Barnes about a new study that you're going to be doing about COVID-19 and the impact on kids. You want to share a little bit about that?
Sure. It was funded by the CTSI collaborative grant between Children's and our department. And we're going to recruit 200 families to better understand protective factors. And we'll be recruiting kids from Voyager as well. So it should be interesting to find out what some of those protective factors are and what's helping kids the most right now. And we're going to randomize the kids as well so that they have access to some online guided mindfulness activities that are developmentally appropriate that they can do with their parents or on their own if they're older. Because we do think that those kinds of relaxation exercises can have a pretty big impact. And there are, of course, a number of apps out there for that, including some that are specific, a little more specific for kids on the autism spectrum. And so we think that, having that's preparatory to anything, I think, if a family's going in for a visit, a medical visit or a procedure, that relaxation practice be part of that. It's something that the child can tap into once they're in the office. But it's really hard to tap into it if they haven't practiced it and gotten that muscle memory for doing it.
So just, building off of that, are there tips for providers for how they can help a person with autism manage anxiety in the moment, or help the families manage anxiety?
I think one of the things that's important to help kids remember is that they're safe in the moment. It's when you're feeling out of control, it's hard to remember that. That only works if the horse hasn't left the barn, I think. So if the horse has left the barn and there's just a panic reaction or an anxiety reaction that's happening, it's best to ride that out and wait. We may jump to try to help, and it can make things worse. So giving somebody the space and time, which probably is at most 20 or 30 minutes to calm down, is best, and reschedule the visit if you have to. it's pretty hard to talk somebody out of an anxiety reaction. If you think about when you yourself are feeling anxious, if somebody tells you to take a deep breath, especially if you're really in the most ramped up physiological states you could be in, you're not going to be able to do it. So if it's already at the point of tears or yelling and screaming or flopping around on the floor, you have to give it some time. For some kids, they might need to be, have a pre-medication option like hydroxyzine. Often works pretty well, or a benzodiazepine, although I'd probably go with hydroxyzine first.
There's a question from the Q&A, which I think is particularly pertinent now that we're trying to limit staff. Child family life isn't available as much as they sometimes have been. So Dr. Vey was mentioning how helpful they are in kind of walking kids through a visit, but are there some of the kind of standard communication approaches and social stories that you guys have alluded to that we as a faculty group or clinical group could kind of get some baseline skills that we all have? So if there's a day when child family life isn't there, what are some best practices that you would recommend for us?
Yeah, that's a great question. And a lot of the tools that I've been finding online, like that nice Boston Children's Hospital social narrative, were created by child life specialists in those institutions. So yeah, it does help when you have a team of people who already know how to make these kinds of tools for children available. But I think we can all take pictures of what our equipment looks like, what our waiting rooms look like, what we look like. So one of our social stories, we're having pictures of ourselves, and then we're going to put all our masks or whatever we end up using on, and so they can have a picture of both versions of us prior to the visit. And you can post these things on your clinic website so people can download them and look at them. But I also think just making sure to have use visuals as you're talking to children. So before you bring out whatever piece of equipment you're going to use, the blood pressure cuff, the stethoscope, whatever, show it to them, demonstrate it. You probably already do this with all children. Demonstrate it on the parent or someone else before introducing it to the child, and just making sure to budget the time to do some of those things. We're hoping to have some of these tools available on our Voyager website that, they'll probably be the photos specific to Voyager, but there might be things you can adapt for your own clinic as well. Do other panelists have ideas to share? It looks like there's another question that just came in for Becky. What are some ways that parents can continue to support social skills development during this time of social distancing and changes in availability of group social skills training? Yeah, I've heard consistently from my patients I've seen on telehealth that they are worried their child is losing social skills because of their reduced opportunities now.
Yeah, thanks, Alicia. So we're doing some kind of virtual therapy around social skills right now, where we'll do individual sessions for families that we know had their social skills programming disrupted. So we're doing some individual coaching just around maintaining and building those skills for when they can see their friends again. I'll say that a lot of my families are seeing friends again because that is something that they have just prioritized for their child. So they've chosen, one or two other families that they're creating one of their kind of social pods with, that they've started doing some socially distanced get-togethers. But I know for our teens that families really worry about this, but also I'm hearing from a lot of our teens with autism that they're really worried that maybe they missed out on their opportunity to make friends. And so now that they are quarantined and not in school, they're really, really worried if they will ever have an opportunity to do the things that they were supposed to be doing in their social skills training prior. So I would say there's kind of this co-occurring skill building, but also anxiety management and problem solving around just how can you do things virtually right now. And kids are getting really, really creative. So kids will take their phones and do FaceTime, like on a bike ride together, or they will, each take a lunch out to their backyard and have lunch together. So in some ways, I'm seeing some of our kids really do a little bit better with this, and the virtual piece reduces some of that social pressure of the face-to-face interactions for a lot of kids. So it's actually been a nice way to learn the skills, do some practice, get more practice with your family, so that when you can see families again and see other kids again, you're a little more ready to go.
And you are, right, Becky, offering some virtual social skills groups right now, parent education and social skill groups.
Exactly. Yep. We're doing some kind of booster sessions for families that have done social skills training, or maybe had their social groups disrupted when we couldn't be in clinic any longer. And then we will start running new social skills groups for new families who want to come and do the virtual version of that social skills group, in addition to some anxiety programming and individual therapy. So lots of kind of multifaceted support around that for students, but also a lot for parents who are now becoming more of those social coaches on a regular basis.
I'm wondering, maybe for Julie, since I know Voyager has started seeing some patients in person, what are the kinds of preparations that you're doing? Things that are different now to I guess limit the dangers of COVID with patients?
Sure. Well, the neuropsychological evaluations tend to be lengthy appointments, 1, 2, 3 hours, depending on the age of the child and how well they can tolerate it. And so, our policy is always that the parents be present, but they usually wait in our waiting room, but we can't have that many families all in a waiting room together. So we are now rooming families over 2 rooms. So the child is in one room with a fully protected, all the PPE necessary tester, and then the parents wait in their own room next door. So all the conversations that we have, we do virtually. So when we interview the parents about the status of the child's functioning, what their concerns are, that's done virtually. And then we limit all of the face-to-face interaction just to what's necessary for the actual testing, direct quantifying of skills. And as soon as that's over, we then dismiss, and we describe our results to the parents and give our advice based on, via a virtual method. So we're doing everything we can to reduce that. I have had conversations, I know my colleagues have had conversations with families just to prepare them, to bring things to do. Ideally, for families who have devices actually help in these circumstances. I've had conversations with parents about, I think I said earlier, about what they anticipate their comfort level will be with masks, the child's comfort level. So far, it has not been a huge issue.
It sounds like it's a lot more prep and time and multiple steps that used to be like one step, right?
Right. I mean, we're staggering check-in times so that there isn't the long line at the check-in counter, and we're also staggering the appointments so that we don't kind of run into everyone dismissing at once. We're keeping our hallways monitored because by nature of the length of our appointments, there's need for restroom use, there's need for snacks and meals and that sort of thing. So we're really modifying our clinic flow, and that's not something I could possibly take credit for, but it's been a really involved, complicated process to make sure everyone's safe and thought out and rolled out over time.
And thanks, Rich Fahey, for the suggestion of putting the one-page forms on our website for parents. I think that's a great idea. The get to know you forms for the kids. I think that should be a tool that we're using all the time, frankly, but hopefully COVID, if there's one nice outcome, maybe we start to be more mindful of some of these tools going forward.
I think we're at time, but thank you all so much for sharing your expertise today, and particularly appreciated your attention to all the current events that are impacting our families and the great work that you're doing. And I'll connect with you offline because it looked like you had a ton of really helpful resources that I want to make sure we make available for our audience today.
Thank you.
Thanks, everyone.
Thanks.